Hi, and welcome to an introduction to interprofessional collaboration for medical students. My name is Bethany Dizer. I am a registered nurse and a nurse practitioner, and I am the recipient of one of the Dell Postdoctoral Fellowship Awards through the College of Osteopathic Medicine. And as part of that project, I am performing this educational opportunity for medical students, nursing students, and direct care workers to get together and learn together to provide services for older adults receiving long-term supports and services. So the overall mission of this project is to prepare different professionals with the competencies they need to learn more about working with older adults getting long-term supports and services, as well as to practice their skills and strategies for interprofessional collaboration. The structure of the program: you'll have today's brief video. It reviews some key concepts and ideas and introduces some potential communication and teamwork strategies. And then on the 8th, you'll get together with a group of direct care workers to talk about some relevant case scenarios and problem solve some strategies for working with older adults. And then on the 15th, you'll get together the medical students, the nursing students, and the direct care workers, and you'll all work together on 2 unfolding case studies, and you'll perform true interdisciplinary care planning for those older adults. All the scenarios have been selected to address the shared competencies when it comes to providing long-term supports and services for older adults that are performed by physicians, nurses, and direct care workers. So I really hope that this will be a great opportunity for you to practice some interprofessional collaboration, as well as hopefully learn something new about working with older adults receiving long-term supports and services, which is one of my favorite areas of professional practice as a nurse and a nurse practitioner. And hopefully you can relate to that in your future careers. So let's jump right in. Our learning objectives today: we're just going to go through, define the term direct care worker, describe some challenges and future directions of a strong direct care worker workforce, also define interprofessional education as well as interprofessional collaboration, relate interprofessional collaboration to the practice of medicine, define person-centered thinking, and relate person-centered thinking to the physician role. Finally, we'll talk a little bit about geriatric syndromes, as well as a couple of strategies for interdisciplinary communication that you might be able to use in our group activities. So what is a direct care worker? Direct care worker is a paid provider of hands-on care, often working with older adults and people with disabilities. Direct care workers, a lot of their work involves supporting people in completing their activities of daily living or instrumental activities of daily living. Direct care workers also help to support meaningful community participation and the maintenance of meaningful relationships for the individuals that they serve. And the term direct care worker may be new to you. It's being more widely adopted because it's a very descriptive term about what a direct care worker does, is described in their title, but also because it avoids language that relies on dependence on another profession, such as assistant or aide. And I think that's an important transition as we are trying to recognize the autonomous professional work that's performed by direct care workers. But you may have also met some direct care workers with other job titles like certified nursing assistant or home health aide, personal care assistant, or DSP, which is a direct service provider. That's a term often used in community mental health settings. Direct care workers, you've probably encountered some in your clinical practice experience. They work all over: long-term care facilities, in homes of the individuals in the community, in adult day services, or even in supported work environments, doing work like vocational rehab coaching. The direct care workforce, as you may be familiar, is in a tenuous position, especially as the population is aging. There's a projected shortage of direct care workers. There was a small increase in the number of direct care workers in the past decade, but it unfortunately amounted to an actual 1.5% decline in the number of direct care workers per capita. Here in Michigan, the estimate is about 36,000 more direct care workers are needed right now. And there are several factors that contribute to the shortage of direct care workers, particularly low pay, patterns of discrimination facing individuals who work as direct care workers, and also Reports of lack of decision making in the workplace. The median hourly wage range for direct care workers in Michigan is currently anywhere from 11.85 to 15.18 an hour. Um, and that means that about 50% of direct care workers live in or near poverty. So it's very challenging for people to maintain engagement in this workforce. That's a hard um, challenge facing this workforce, and it is our hope to help improve it. And there has been some data collected that suggests various factors that lead to direct care worker retention. Some of those include leadership and staff empowerment, decentralized organizational structures. Thinking back to some of those workplaces where direct care workers live, some of them have very hierarchical or rigid leadership structures and organization. Also, direct care workers in surveys report improved communication in the workplace and training, better quality and better access to training for their professional roles, as well as training that specifically supports their understanding of health and disease states or conditions of the people that they work with. And of course, as we saw on the last slide, that lack of decision making or respect for decision making. Direct care workers report that participation in care planning for the people they work with can improve retention in the workplace. And if you're thinking right now, well, what is the importance of the direct care worker workforce to a physician? I would encourage you to consider the fact that you are probably sharing a lot of these individuals that direct care workers work with may also be seeing you for your physician services. And so ensuring that there's a robust direct care worker workforce to support those individuals to help meet the medical goals that you agree to with them and to support them in achieving their personal goals, like living independently in the community or completing their activities of daily living with an appropriate amount of support, are all significant to a physician. As well as you might also recognize that there's some shared workplaces between physicians and direct care workers on that last slide. So it's always important to consider things like communication and training and workplace structure and organizational leadership. If they are unsatisfactory to direct care workers, they may also be unsatisfactory to the physicians that work in that setting. So making sure that it is a workplace culture and environment that is conducive to all the professionals working there to be able to stay working there and do their work as best as possible is really important for all of us. The other major development here in the state of Michigan in the direct care worker workforce was the adoption of 15 competency recommendations for direct care workers. So we discussed how there's a real patchwork, a real alphabet soup of those different direct care worker jobs. And along with that comes a real patchwork of training requirements or credentialing. So some of those may be time-based, some may have very little training, some have much more. And so there's an inconsistency between those. And these 15 competency recommendations address all of the key skills, knowledge, and requirements necessary to work as a direct care worker. The goal of using a competency-based training framework is to professionalize the work of direct care workers, promote the career path to potentially interested candidates, and also to improve the quality of care that's provided to individuals by direct care workers, right? To make sure that you're providing services by someone who has demonstrated proficiency and competency in each of these key areas. It also helps the other professions who work with direct care workers to understand what their work entails and what it means to achieve competency in their skills and knowledge base that's required for them. Quick definition of interprofessional collaboration. The World Health defines IPC as the provision of comprehensive quality services across settings and disciplines by multiple workers. So that's just acknowledging that it's any mix of different disciplines, and there's a lot. There's medicine, nursing, direct care work, as well as dentistry, pharmacy, physical therapy. Don't forget the speech therapists when you talk about physical and occupational therapy. There's a lot of different disciplines that really all bring something different to the table. So collaborating with everyone is a key competency for physicians. And then interprofessional education just refers to activities that occur when two or more professionals learn about, from, and with each other. And the goal is to improve effective collaboration as well as the health outcomes of the people that they work with. So that is what we are here to do in this program. The Interprofessional Education Collaborative, IPEC, which includes credentialing bodies for both nursing and medical training, outlines 4 key competencies to demonstrate effective interprofessional collaboration. So there's 4 categories of things that are required of you to act as a physician who's competent in interprofessional collaboration. Really identifying and understanding shared values and ethics in interprofessional practice, learning about and respecting the various roles and responsibilities of all the interprofessional team members, demonstrating effective interprofessional communication, and finally, establishing and following through on effective interprofessional teamwork. So let's just put those into context alongside some of those physician roles and competencies that you may be working on in your classwork and in your clinical experience. So on the left-hand side, you'll see physician roles that involve other professions. So you may be out in the field doing things like ordering treatments that will be administered by other professionals, collecting findings that are reported to you by other professions, and then interpreting them as part of your medical care plan. I was a nurse for many years. I passed a lot of medications that were ordered by a physician, as well as called many physicians to report abnormal findings. And when I did that, that was to always facilitate the performance of that medical care plan that helps physicians to achieve the outcomes that they had set for the people that they work with. That's in a little bit of contrast to this right-hand column where we talk about a physician who's a member of the interprofessional team demonstrating interprofessional competencies. So that would include understanding and learning more about the different team member roles, performing teamwork in such a way that the interactions are agreed upon, there's shared governance to the performance of the team activities, making sure that you're engaging in information sharing that's accurate and meaningful, and also sharing accountability to an agreed upon value set. So how is that a little bit different? It's different in that there's a shared approach to the work and the collaboration, and the only goals are not the performance of just the medical interventions for medical outcomes, right? It's shared amongst all the professions, and it addresses all the different goals and outcomes that are of interest to all the different team members. The challenge here, I think there's really 2 challenges to interprofessional collaboration. The first challenge is maintaining your own professional roles, right? Like accomplishing all those physician roles that are listed in that left-hand column and being a good member of the interprofessional team. It's a lot of work to manage. The second challenge is when you are doing shared decision making and shared care planning, and sometimes those desired outcomes or goals between professions are not always the same. And not only are they not the same, sometimes they're in direct conflict with one another. So that can be a real challenge. And it's important that the teamwork dynamics have a plan for overcoming some of those discrepancies between different professions. So here's some examples where we're talking about how do direct care workers and physicians collaborate and what's the nature of that collaboration. So direct care workers collaborate with physicians by making observations that are of interest to the physician related to the person's health or illness. So maybe a direct care worker is reporting symptoms like pain or response to a treatment, as well as social emotional findings. The direct care worker is also supporting the person to address some health promotion activities that the physician might indicate or be interested in. Things like completing hygiene tasks, participating in activity or exercise, and maintaining healthy sleep-wake patterns. On the other hand, physicians collaborate with direct care workers and provide support for direct care workers' job performance by ensuring people are in their most optimal health state, right? People need optimal health to be able to facilitate meaningful relationships and participate in community engagement and be autonomous in the community. To be able to successfully live at home with your direct care workers support, you really need adequate symptom control. You need access to the right type of mobility or supportive equipment and management of your disease progression. Physicians also support the work of direct care workers by understanding the person and what matters most to them. So physicians can be a huge provider of mutual advocacy for a shared person that the direct care worker and physician are both caring for. And physicians can offer some good insight into what a good day will look like because of their understanding of different disease states, and particularly when it comes to the progression of chronic illnesses, and can be of great support to direct care workers who are trying to work with those individuals in the home setting. I feel like I keep talking about person-centered thinking, and I have yet to define it, so I'm going to go ahead and do that on this slide. So person-centered thinking, according to the CMS definition here, is the integrated healthcare services delivered in a setting and manner that is responsive to the individual and their goals, values, and preferences in a system that empowers patients and providers to make effective care plans together. That's a mouthful. And what are some things we've noticed? First, I'd like to basically sum it up in saying person-centered thinking as it applies to medical care means that you're providing care that revolves around the person rather than responsive to just their disease state, or responsive to the setting where they are receiving care, or responsive to the physician, right? The physician's priorities, professional values, professional training, right? It's all about centering that person in all of your decision making. You'll also notice that I am using person-centered rather than patient-centered. And I know CMS right there in that definition does use the term patient. And you might notice that direct care workers very often refer to the people they work with as person or an individual, or maybe even just by their name, whereas physicians are more apt to say patient. And what is the difference and why does it matter? I like to think of it this way. A person is always a person, but they're not always a patient. And sometimes in providing person-centered thinking, you have to think about that person outside of their relationship to you as a patient, right? You have to think about them being a person in the community, being a person who receives care from direct care workers, a person who's in relation to other people. I know that a lot of your work probably focuses on the dynamics of the physician-patient relationship and relating to your patients and providing patient care. And I don't think person-centered thinking undermines that or discredits that. I think it's just another way to add in a more holistic approach to the person and their overall interprofessional supports and services that they are getting across the spectrum throughout the community and from other individuals. So that's a little bit about person-centered thinking. I also find that using these principles of person-centered thinking and thinking about the person outside of just my relationship helps me to address some of those interprofessional challenges we talked about when the goals of the different professions vary and are in conflict with one another. It can be really hard to provide interprofessional collaboration activities. But if you get together, you have these disparate professional priorities, and you then try to imagine what the person-centered approach is, or work with the person to identify their priorities and values, it can usually settle some of those conflicts. So what are some examples of person-centered medical care? What does it look like versus what does it not look like? On the left-hand column, a person-centered approach to medical care might include asking people, what matters most to you? What do you want out of your care? And describe a good day to me. What do you do in a good day? Not so person-centered is the way that we do institutional scheduling and staffing, right? This is when we eat breakfast, this is when you take your pills, this is how you take a bath, and this is who's going to be taking care of you. it's not really incorporating any of that person's individual preferences and needs. Anytime we describe someone as non-compliant, I always think about, well, what does that really mean? It's demeaning and dismisses a person's autonomy. Instead, I like to flip it. My knee-jerk reaction when I hear that is to turn to the person and think, like, well, maybe your medication regimen was non-compliant with that person's preferences, needs, and value set. So it's just a different way of approaching how we interpret our patients' priority, the people that we work with, their priorities and needs. And finally, this is a phrase that I used to hear often in the hospital, sometimes from physicians, sometimes from nurses. And I find it to be really not person-centered, right? Sometimes we'll be at rounds, making a list of all the things we need to do. And the last one is we need to get them to sign a DNR. And I think whenever I've heard it, it comes from an almost person-centered place, right? I think the clinician who says something like that is thinking about how do we facilitate a more peaceful end of life to someone with a very limited or guarded prognosis. But describing it as a task in that way undermines the autonomy of that person. Instead, our approach should be to describe what we do as counseling or teaching or supporting people as they're making decisions. And then, of course, honoring the decisions that they make would be a person-centered approach to end-of-life planning. This slide, the next couple slides here, we're just going to go through the geriatric syndromes quickly, and you'll notice that a lot of our case studies address some of these geriatric syndromes. So this isn't the last time you might hear about some of these. But just a quick definition, geriatric syndromes is a term that describes a complicated series of problems that cross the boundaries of any single body system or discipline. Geriatric syndromes impact someone's quality of life as well as their functional abilities. Here are some examples: falls and dizziness, cognitive impairment, which can include all of our different dementias, pressure ulcers, any kind of pressure injury, sleep disorders, hearing and vision disorders, urinary incontinence, weight loss or other nutrition problems, and then finally bowel problems like constipation and fecal incontinence, right? Very often in older adults, they have multiple causes or potentially variable causes, as well as multiple effects that cross any single body system and impact function and quality of life. What's this slide? This is just to summarize and categorize those different geriatric syndromes, because once you put it into the perspective of these different categories, you can start to appreciate the overlapping work of physicians, nurses, and direct care workers when it comes to addressing the geriatric syndromes. We all share responsibility in supporting people who are experiencing geriatric syndromes, but we may do very different tasks. For example, elimination, maybe it will impact your prescribing or dietary recommendations to a person. As a physician, maybe for a direct care worker, they are making more supportive plans to support someone as they need support with going to the bathroom or hygiene. So what are some different professional responsibilities when it comes to geriatric syndromes? The direct care worker there does quite a bit, right? They're working with older adults to support their ADL or IEDL performance, engaging in meaningful activities, but also monitoring, reporting, and documenting changes. They get very familiar with the experience and the supports and service needs of older adults who are experiencing geriatric syndromes. And because of that closeness and that the nature of their work, direct care workers can be a very good resource in identifying very nuanced changes to those patterns. And that includes notifying emergency response when something happens. Nurses care for older adults with geriatric syndromes by recognizing the impact of their current health status on the development and progression of the geriatric syndrome. They also develop nursing care plans that are informed by the required functional supports, medical interventions, and the goals set in partnership with the person. Physicians working with older adults are very often taking an inventory of someone's functional status and then selecting the appropriate supportive, palliative, or curative treatments for the myriad of underlying causes or resulting effects that relate to those geriatric syndromes, right? I guess this is where I'd put in my recommendations when doing a comprehensive geriatric assessment. Make sure you're really including that full functional inventory, right? It's such a huge source of information, and you'll pick up quite a bit more than simply what they do for their ADL status. When you ask about these things, it's really where you'll see the geriatric syndromes come out. And the way I like to do it to keep it real open-ended when I'm doing a geriatric assessment is I might ask someone to walk me through their whole day. Start with when you wake up. What happens? How do you go about your day? And listen as they tell me what it takes for them to perform their own activities of daily living. Or sometimes I go through as a checklist. Tell me about how you get washed up in the morning or how you take a shower. I find that offers a lot of insight into the geriatric syndromes. I'm going to wrap up here with a little talk about effective interprofessional communication. When and why do we do communication across interprofessional boundaries? Anytime there's a change in condition, when someone experiences an adverse event, to describe the response to treatment, whether it's good or bad, when we're transferring care between people or places, when we're trying to adopt a systems-wide change, maybe changing practice or procedure, and then also to make sure that we're following up and performing good work sharing, right? There's a lot of tasks that need to get done amongst various professionals, and so making sure we have a plan for doing those correctly. Effective communication, remember, is always going to be focused and really clear, and it can help to avoid unwanted outcomes from misunderstandings. So my first little tool, and these all come from the AHRQ, so a national organization for patient safety. My first tool, this is one I use with registered nursing students. And I use it as a worksheet, and we practice scenarios where they're either giving a report to other nurses, or maybe they're calling a physician or another provider with change of condition related to someone that they're taking care of in hypothetical or real clinical practice. So you want to just make sure that you're using a templated tool like this when you want to ensure that there's no lost information, right? And it also helps us to overcome the barriers within our own profession, right? We're so used to learning how we communicate our significant findings and our desired outcomes that might not be totally meaningful to other professions. So this puts things in a context that everyone can use and make sure none of the steps are skipped. So you want to start out just introducing yourself and make sure you're talking about the right person. Give the headline, the problem, then provide any pertinent, relevant details from the background, and then give your assessment of what you think is going on. What do you judge is going on in this situation? And then give your recommendation. And once you put all those parts in, the loop is closed by the person responding to you will either agree, disagree, or change the recommendation and give you feedback on it, right? The other tool are the cuss words. I don't know that they're supposed to call them cuss words, but I think that it's nice to know that there's some cuss words that are acceptable in the workplace, because there are a lot that are not. But the idea behind cuss words is using stop the line language. So these phrases are standardized, and this concept is adopted mostly in the hospital to overcome some of the hierarchical and power dynamics that are present in clinical workplaces like hospitals, just to really give every member of the team the opportunity to stop the line and address potential safety or negative outcome problems. So it gives everyone the power to say, I have a concern, and state their problem. If it's not responded to and addressed appropriately, you might escalate to, I'm feeling really uncertain about this. And then finally, I'm sure you're thinking, if someone said this to me, you would stop everything and address it, right? If someone said, this is a safety issue, you would need to come to an agreement about what's an acceptable course of action. Which brings me to my last little slide, and I don't know if this will be helpful. Hopefully none of these kind of issues arise in our interprofessional collaboration activity, but if they do, whenever there's a disagreement across professions, I try to always remember these little tips. First, I presume that everyone's concern is in good faith, right? And geared towards safety and protecting outcomes for the people that we work with. I also find that if I'm able to clarify and give my rationale or cite good evidence, it really improves my trustworthiness with those coworkers and in that workplace in the future. I always see the opportunity in double checking because when you hear about people who've made significant errors, they just did not see it coming. It just happened and they never would have double checked or thought anything of it. So it's an opportunity for this to be that double check. To settle disagreements, make sure you get help, know who trusted sources are, and share tools and access to information. A lot of times, disagreements just come up from not being on the same page as someone else. So, thank you for your attention. I'm so excited to meet all of you. I appreciate all your time and support. If you have any questions, feel free to contact me via email between now and Saturday. Otherwise, I will see you all then. Thank you. Get my cursor to stop here. Have a good one.